So thank you so much for having me today to present about this really unique project that I'm excited to share the results of you, but also with the process, which I thought was quite an interesting way that we at DataNB can help support people like you within government. My name is Dr. Sandra McGallis, and I'm a research associate at DataNB at the University of New Brunswick and Fredericton. And I'm an epidemiologist by training, so I get to use the data that we have at DataNB to inform on population health. And this was one really important project that I got to do in collaboration with partners within public health and a broader stakeholder group that was helping to inform the program review of the Healthy Families, Healthy Babies program. So this presentation focuses specifically on the postnatal part of the home visiting program, but the program also includes targeted services for the prenatal services that are provided to the families as well. So just as a background, um, sorry. Just as a background, the Healthy Families, Healthy Babies is a GNB, Department of Health public health program. It's a postnatal program, or this part that I'm talking about today is a postnatal program, home-based. It's an early intervention service really aiming to promote healthy development, and it's provided by public health nurses and public health dietitians over the first 2 years of life. So I mentioned the Healthy Families, Healthy Babies program is broader, and so specifically, I'm going to be focusing in on the postnatal program, but of course, there's other parts of this program. Um, so it's a secondary prevention program really aiming to target at-risk first-time mothers and their infants who are at risk of health or developmental concerns, mainly arising from congenital or acquired health challenges, but also developmental factors. And an important contribution to eligibility to this program, as we saw through our data, are the family interaction factors. So these include family and social factors that make the family unit more vulnerable to both health and developmental challenges through the early years of life. And so this program is aiming to support that and prevent those negative outcomes. And so the eligibility for the program is determined at a newborn screening that's done in New Brunswick hospitals after birth. And so this is a universal screening that is also a component of the Healthy Families, Healthy Babies program. And it's called, the screening is called the Public Health Priority Assessment. And so this is done consistently across all births. It's an important component of the methodology, but also an important opportunity to identify these families. All right. So as was mentioned, we've just rebranded from NB-IRDT to DataNB, and our functions, while our name has changed, our functions remain the same. Oh, I'm seeing that this isn't actually the same. Oh, never mind. So the slide title doesn't align with the content. I think this is just a continuation of that original slide. So really giving additional background on the program. So the program what is currently under review, and the program. Postnatal program, it's was operating with the same inclusion criteria since 2011. The objective of the program review was to evaluate the impact on child health and development. So public health partnered with us at DataNB to undertake a summative evaluation, so really focusing on outcomes of the program. And this was, as I mentioned, specifically focused on the postnatal program. So the ability for us at DataNB to link data holdings provides really that opportunity to evaluate the longer term outcomes. And in this project, we looked at children who were enrolled in this program and how they fared at preschool age. So looking at school readiness, the ability to link across different departments, and over time is one of the benefits that we're able to have with the ability to link these data. So the research goal specifically was to evaluate the short and longer term impacts of participation in the postnatal Healthy Families, Healthy Babies targeted services on selected child health and developmental outcomes. And I'll fill you in on all the details. So our specific research questions were really among eligible first-time moms. Are the babies who participated in the program, are they more likely than those who didn't participate to be breastfeeding at the time of the Healthy Toddler Assessment? And for those who aren't aware, Healthy Toddler Assessment is another one of the universal components of the Healthy Families, Healthy Babies programming, and is intended to help assess at a later point, and typically done around the age of 18 months. And at that time point, were they also more likely to report a longer duration of breastfeeding? We were also interested in addition to breastfeeding child development. And so we were interested in seeing whether those who participated in the postnatal program, if they were less likely to be identified as having a problem area in development at the time of that healthy toddler at 18 months assessment. But as I mentioned earlier, we also linked out to preschool. So the Department of Education Early Childhood Development has a preschool assessment that children do prior to entering kindergarten. And so we were able to link out to this data to identify whether the children who participated in the program were less likely to have a problem area identified in development during that assessment. It's not getting into the nitty-gritty details of what we did. So we established a prospective cohort study of all births in New Brunswick between April 1st, 2012 and March 31st, 2014. So this cohort was established within the administrative data holdings that we have. So what we did was we identified all births in New Brunswick using the newborn screening assessment, which is the public health priority assessment that's completed as part of the Healthy Families, Healthy Babies Universal Programming. And that helped us to identify who participated in the program and some characteristics of who didn't participate in the program as well. We were then able to link that newborn assessment with developmental assessments at 18 months. And the white box here is to designate that these two data sets are held within the Department of Health. And then this gray arrow that links out to school readiness is now data that is provided by the Education Department and is assessments that would not naturally be linked within a government institution. So how do we pick the individuals to participate in this study? So I mentioned we identified all births in that period. I wanted to make sure we found people who were like the program participants. And so we were really interested in identifying people who were parenting for the first time and met one of the following criteria for participation in the study. And so including whether they were enrolled in the prenatal program or whether they had a high score, which represents the factors that I had mentioned earlier, specifically developmental, congenital, as well as family interactions. So of all births in New Brunswick, oh, sorry, there's a mosquito, if you can imagine, for those of first-time births that did not participate in the program and had not parented a child for more than 6 months, were identified to serve as the control group for the comparison to the outcomes of the program participants. But as you can imagine, I mentioned we tried to identify all first-time births, and I mentioned that the program is really targeting a specific population. So it was really important for us to identify among all of those individuals who may be eligible for the program. We really wanted to focus in on those who were similar to those who did participate in the program. So we used a special methodology that's called propensity score matching that allowed us to use a lot of information from the data we have to define an approach that allows us to find non-participants who are similar with respect to those characteristics. And so it was important for us to use this approach as a mechanism to control for confounding. We use a wide variety of information, both at the individual level as well as the area level. But one important limitation is we don't have information on both parents. Are the data we have are able to link is really focused on that birthing parent. And then we also lack some important socioeconomic information at the individual level. And so we supplement that with the area level. For example, provincially, we don't know or have data on income, but we're able to use sort of neighborhood income to capture some of that information because we can't have access to that currently. So this for the data geeks in the room would be what we looked at in terms of our propensity scores for the whole group. So here 0 are those who didn't participate and 1 are those who did. And so we want the propensity scores for the zeros to be similar to the ones. And when that happens, we say that the groups are somewhat balanced. So as you can see, like the zeros on the before, there's a high number of people with a 0 or close to 0. So they're not likely to participate. Their propensity to participate in the program is very low. So they shouldn't be in that comparison group. So what one of the approaches that's proposed is to use a matching approach that finds a person who's a 0 that's like the 1 or closest to the 1. It's called nearest neighbor if you're familiar. And what you see on the other side is that matched group. So still, obviously, there's a lot of people who are more on the lower end. We see more similarity, obviously, in the curves, but they're still imbalanced. So this led us to, first, great job for public health, really enrolling those more vulnerable families. But also it created a bit of a need for us to do some additional adjustments through our modeling. And so that's what we did to better provide a robust estimate. But in the end, there will always be sort of that ability for that mismatch. So the program participants have characteristics that make them more vulnerable and more likely to have negative outcomes, if that is clearer from those non-statistical perspectives. So what did we end up with all these methods? We ended up with about 1,200 program participants, so people who were enrolled at birth and followed for at least the longest 2 years of life. Among the full sample that we identified was just under 5,000, and we were able to match 1 non-participant to each participant. Some of them were able to add a few others that fit within the scope or within the range of those propensity scores. And so this served as our comparison group. So I mentioned we looked at several outcomes. So just to sort of better define what those specifically are, we looked at breastfeeding at the healthy toddler assessment. So we looked at duration, so reported duration, how long did you breastfeed, and whether they reported still breastfeeding at that healthy toddler assessment. So as I mentioned, it was around the age of 18 months, but because of scheduling and people's schedules, it sometimes differed from that specific period. We also looked at the healthy toddler for the developmental. This is the ages and stages questionnaire for those who are familiar. It includes several domains. Sorry, I don't know if you can see that. It includes several domains, including communication, gross motor, fine motor, problem solving, and personal social skills. And it's rated using 3 levels, white, gray, and dark. White is appropriate development on all levels. Gray is a potential developmental concern. And this is typically just the information from this assessment is communicated to the families. When a child receives a dark, that's typically when a referral would be made to some service that helps to support the challenge that may have been identified through the ages and stages questionnaire. So as I mentioned, we linked out to EACD data and we looked at school readiness at the age of 4. So the IDA, or the Early Years Evaluation Direct Assessment, so we just say IDA for short. Similar to the ages and stages, it's assessing different domains of the child. This one's specifically awareness, cognitive, language, communication, and physical development, both fine and gross motor. And so children attend an assessment, and based on some activities, they're graded in these different domains as green, yellow, or red. So green being appropriate development on all levels, some development, and then significant development. And the same type of thing. When children are identified as significant development, there's strategies put in place to help prepare them so that when they enter kindergarten in the subsequent school year, they'll be more ready. So now getting into the results, or a little bit of the results. So one of the important limitations of the data is that we identified a lower response rate than maybe ideal for doing these types of analyses. So what we find is the response rate of participation of the healthy toddler assessment is quite low. And for those who participated in the program, it was actually among the highest. So about 60% of program participants attend the HTA as compared to just about 50% of all first-time births in that period of time. When we look at the IDA, or that school readiness assessment, we see that in fact that proportion of completion actually increases quite a bit among all births, but is quite low among the program participants. So the HTA, these program participants is done within the time frame that the program runs, whereas the IDA is done at age 4. So that's after the Healthy Families, Healthy Babies postnatal program would have ended. So I mentioned a little bit about our data analysis strategy in terms of the groups we were comparing. So of course we use descriptives, and then we use some advanced regression modeling approaches to be able to adjust for additional variables that allow us to consider differences amongst these groups. And so we looked at a few different analyses, unadjusted. So unadjusted would be a comparison of program participants to all other births. And then anything you see with PS, which is propensity score, that's comparing to those non-participants who we found that were similar to the participants. Between adjusted and matched, the nuances for the purposes of a presentation and the results are very similar, but it was just a way for us to make sure that the result was robust to the methodology that we used. And each of the graphs you'll see present relative measures of risk and 95% confidence intervals. So just to orient those who aren't familiar with what I'm even saying, so higher values on any of these that indicate that postnatal participants have higher levels than non-participants. So always think about the postnatal participants as sort of being on the top end of that relative measure. Values that are close to the vertical red line, that means no difference. And they're similar with respect to their outcomes. I mentioned the 95% confidence intervals. When those are more narrow, we think that we have more confidence in that relative measure. And if those cross that red line, then that indicates that there's actually indicating that there's not evidence to suggest that there's a difference between the groups. So let's get into the results. So as I mentioned, it was really important for us to find group who were like the postnatal participants, because as you can see here, they're not really like all first-time moms that we found in the data. So they were younger than those than all of the births. They were more likely to be 3.5 times more likely to be on social assistance. They were more likely to be single. They were also more likely to live in areas that had more residential instability. So this isn't the individuals, but about their neighborhood. So it's a characteristic that might be important to the vulnerabilities that create the negative health outcomes that we're trying to prevent in these programs. As you can see, the match sample much better than the total population, but still there was some differences according to some factors. Here we see that the match group has less likelihood of being on social assistance, and this is social development social assistance than our postnatal participants, for example. And there was some other characteristics that were also a little bit different. For example, our match samples were more likely to be immigrants, for example, as another characteristic not shown here. All right, so these are our descriptive statistics. What we found was that postnatal participants at the time of 18 months, 10% of them reported breastfeeding, as compared to only 5% of those who were in the match sample. So this was providing some evidence that the postnatal program was impacting breastfeeding rates at this level. The regression estimates confirmed what we saw in the descriptive statistics. And so what we found was that postnatal participants were 60% more likely than all first-time moms to be breastfeeding. So that was interesting finding for us because we expected that all the outcomes among all the births would always be better than we would identify in the postnatal participants. Postnatal participants, when we compared them to people who are families who were like them, we found that there were also twice as likely to be breastfeeding at the time of 18 months. And so this was also giving us some indication that the program was having a positive impact on breastfeeding behaviors. We looked at the duration of breastfeeding at the time of reported at the time of 18 months. We found that a large proportion of all groups breastfed for a month or less. So a month or less also includes people who didn't breastfeed at all, which were coded as 0 time, for example. But when we look at the duration of breastfeeding, we can see that there is definitely a higher proportion of the postnatal participants than the match sample who are breastfeeding for a longer duration based on our descriptive statistics. And based on our regression model estimates, we found that the postnatal participants were less likely to ever breastfeed and to do so for a shorter duration of time than all first-time moms. But when we compare them to moms who are like them, the postnatal participants were as likely to ever breastfeed, so to start or not. But when they do, they were found to breastfeed for a longer duration. So that was additional information that provided some evidence for the positive impacts of breastfeeding from the program. So now switching gears to development. So this again was measured at the time of 18 months, which is, as I mentioned, was potentially limiting based on the response rates or completion. So thinking about who participated and who did not participate, for example. But based on the descriptive statistics, what we found was that postnatal participants had the highest percent of babies who had a developmental concern identified in at least one of the 5 areas. So we just looked at whether they had any of the 5 areas. We didn't look any further into the details of which of the 5 areas or how many of the 5 areas, but at least one of those areas. When we conducted our regression model estimates, we found that the babies of the postnatal participants were twice as likely as babies that all births to have a developmental concern identified in at least one of the 5 developmental areas. And as compared to similar families, the participations were as likely. So this was giving us evidence that the programming wasn't having an impact on the child development as it was in the breastfeeding, for example. When we link out to the school readiness data, we found that, and here red is a developmental concern identified. We found that the program participants had the highest number of children identified as having a significant difficulty, which is the red bars here. So about 41% of them had been identified at that kindergarten assessment to need to have significant difficulty in one of those 5 areas that make them ready for that school. This was similar to the match participants, and as we expected it to be higher than the all births, signifying the need for the program. And so this was confirmed in our regression modeling. So children of the postnatal participants were twice as likely as those who weren't in the program of all births to experience significant difficulty in one of these 5 areas, which is providing compelling evidence for the need for this program because we have these high-risk children. But when we compare them to people or to families who are like them or children who are like them, or from families who are like the postnatal participants, what we find is they're as likely to experience a significant developmental difficulty at that school readiness exam. So the program isn't having that impact on that outcome at this point. We combined the yellow and the red at the school readiness just to see what the impact of that might have. And we found very similar results that we found when we just considered the significant difficulty, which was the red group. We did do some of the exploring differential impacts. We were interested in whether the program outcomes differed depending on whether mom was breastfeeding at birth, for example, on whether the family was on social assistance or not, because we can imagine potentially at an average population level, the program doesn't demonstrate an average effect, but within specific populations, for example, those on social assistance, that perhaps it's having more of an impact, and that provides additional evidence to guide the program review. But we didn't find any compelling evidence, statistically at least, to suggest that there was lesser risk among program participants with these additional risk factors. We also looked at the impact of time in the program, and we did find that the 18-month duration like longer duration in the Healthy Families, Healthy Babies program was associated with a higher likelihood of attending the HTA and still being breastfeeding at the HTA, which is an important indication for the program's ability to reach these folks who are in need of potential referrals, which is the purpose of the assessment. So just to end off with some strengths and limitations of our work. So a couple strengths, really, it's population-based data. So we didn't have to find participants to participate in the study. We were able to use program data and participation data and link it through the process that we have at DataNB to inform on the population that participated. We included people from across New Brunswick. We didn't have to isolate according to a specific region, for example. We look at long-term follow-up. So this is, up till school readiness. We did find some studies that looked further, and there is some evidence to say that while we may not see the shorter term differences as children age into school years, that there is evidence from other countries, not from Canada, that the differences may become more apparent. So it is giving us some, sense of that might be necessary to look a little further out as these children age, of course. We had a very large sample size considering it's a small province and a small program targeting very high risk, but having 1,200 program participants is quite impressive. We were able to link across different outcomes, across different government departments, and we use this, fancy modeling approach to find people who are like the program participants. Of course, with any research, there's limitations. So administrative data is messy. We have expertise in using these data. The staff who worked on these are very well versed in the different aspects, but of course the data weren't meant for research. So we have to acknowledge that. We relied on area level measures of certain individual level characteristics, which I identified previously as being an important limitation. We also had that imperfect match, and so program participants will always look worse off than the non-participants, which was, interesting for the breastfeeding outcomes, but also for those developmental outcomes. But an important limitation is that incomplete follow-up, especially for the breastfeeding outcomes, which are some subsequent work that we've done has really identified that there are very important differences among people who do participate in the HTA and those who don't. And in fact, maybe program participants who have worse characteristics may be more likely to participate, which is good. But those who aren't in the program may be less likely, which then makes the comparison not fair. And we had to stop our follow-up in the cohort. We only had 2012 to 2014 because then COVID happened. So, IDAs didn't happen. They didn't happen in the same way. So we couldn't really continue on that follow-up. So that's a limitation. So just to wrap up, as expected, the children in the program had poorer outcomes than the average child. So, but these results differed when we compared them to families who were similar. So there's an important need for this program because there's clear evidence that the program outcomes are different, or the health outcomes are different. The postnatal program participation was found to have a positive impact on duration of breastfeeding. Those participants were more likely to be breastfeeding at 18 months and to have a longer duration than non-participants. I forgot to say the average duration that we found was about, I think it was 33 days. So participants were on average breastfeeding for 33 days longer than non-participants. We didn't identify evidence for short and long-term impact on child development. They were as likely as non-participants who are like them to be identified as having a developmental concern on both the ages and stages at 18 months and that preschool assessment. But in all, program participants fared more poorly than all children in New Brunswick born over the same period of time. So just wanted to finish off by acknowledging our funding. So the MSSU is the Maritime Spore Support Unit, which receives funding from across the Maritimes, including through GNB and now Research NB. This is an older project before Research NB rebranded as well. And so we do have their old logo, which used to be the New Brunswick Health Research Foundation and is now DataNB. So with that, I thank you for taking the time to listen to the presentation. I hope you found it informative. Yeah, thank you.